Hello, everybody. I'm Chris Paulson. I'm one of the hematologists in Winnipeg. I work at Cancer Care Manitoba, the Cancer Center for the Province of Manitoba and the University of Manitoba. I am happy to give you an introductory lecture to transplant. This will be the first of a series of talks that we put together to help our colleagues across Canada learn more about our field. I think before we get going into the transplant itself, it's good to start off. So we use a common set of terms. Transplant, like many others of areas of medicine that you'll know, is a process in which we have many names for the same process, just to confuse learners. In general, probably the best, most specific name for what we do will be hematopoietic stem cell transplant. So we're transplanting into patients hematopoietic stem cells, the most immature precursors in the bone marrow, with the hope of populating a brand new bone marrow and blood-making compartment. We don't often say that full term, and usually we'll drop the hematopoietic part. So the most common way in which you'll see this described is stem cell transplant. This is fine, at least as of now. There aren't really many other areas of medicine in which stem cells are transplanted, although maybe a problem in 5 or 10 years if we're doing cardiac or renal stem cell transplants to regenerate those organs. You'll often hear the phrase bone marrow transplant or blood and marrow transplant sometimes. Bone marrow transplant specifically refers to transplants done where we take the stem cells directly from the bone marrow, and this was the original term for this process, because that was the only way in which stem cells were procured. We use this now still rarely in a somewhat sloppy fashion. It also comes up a lot in the lay media, so you'll see articles in the Globe and Mail every now and then talking about someone who needs a donor for the bone marrow transplant. It's fine. We usually know what people are talking about when we talk about bone marrow transplant, but if you're talking about specifically in the field, it usually specifically refers to transplant where we get the stem cells from the bone marrow. We'll also sometimes hear the phrase blood and marrow transplant, and that's a little bit more accurate. Blood and marrow transplant refers to a process in which you transplant blood or marrow, but again, it's not the most accurate term. Hematopoietic stem cell transplant is probably the best way to describe this. There are two types of hematopoietic stem cell transplant. There is autologous hematopoietic stem cell transplant, and that's where we take stem cells from a patient, usually a patient with cancer, and most often a patient with a blood cancer, and take their stem cells out and transfuse them back to the patient later on. Allergenic transplant is really a process in which the donor is anyone other than the recipient. So it can be a family member, it can be a volunteer, it's anyone else that is not the patient. It's not entirely obvious as to why you'd want to do an autologous transplant. So what's the point of taking stem cells out of a patient only to give them back to them a few weeks later? This is how I explain it to patients when I see them as a new consult. I tell them that we know that chemotherapy kills cancer cells, and we know that in general, at least, the more chemotherapy we give, the more cancer cells you can kill. So therefore, in that one important way, the bigger the dose, the better. But of course, with bigger doses of chemotherapy, you get more and more side effects. And so typically what oncologists and hematologists will try and do is find that right balance there, enough side effects, enough chemotherapy that it's effective, but not too much chemotherapy that you end up with terrible side effects. Some side effects are hard on patients, but are not life-threatening. So things like nausea and tiredness and hair loss. Other side effects of chemotherapy, though, are life-threatening, and the most important life-threatening side effect of chemotherapy is neutropenia. And that is really the aim of transplant. It's a way for us to give higher than normal doses of chemotherapy in a safer way. Autologous transplant is a shortcut around this one side effect of chemotherapy. We take stem cells out of the patient prior to transplant. We give the patient high-dose chemotherapy, usually in hospital, but sometimes it's done as an outpatient. After the chemotherapy is cleared by the liver and the kidneys, we take stem cells out and infuse them in the patient. And instead of being neutropenic for months, typically blood counts recover a few weeks later. If you like graphs, this is another way to think about it. You can think about a dose-limiting toxicity of chemography, and if the first dose-limiting toxicity of chemotherapy is hematologic. That's normally the end. So say, for example, doses of chemotherapy but beyond 20 milligrams result in unacceptable neutropenia, then you can give 20 milligrams of chemotherapy and then you can cure 20% of people. If, on the other hand, we don't care about hematologic dose-limiting toxicities because we have stem cells in our freezer, we're able to give a higher dose of chemotherapy, say 40 milligrams, until we run into non-hematologic dose-limiting toxicities like cardiac or renal toxicity. And now, because we've doubled our chemotherapy dose, we're able to cure more patients. This higher dose hopefully translates into better outcomes. That's the only reason to do autologous transplant, is to safely deliver higher than normal doses of chemotherapy. In essence, it's a dose intensification strategy, not all that different than giving transfusions or giving GCSF as part of a chemotherapy protocol. It's just a GCSF on steroids, if you would. The process is pretty simple. The patient donates stem cells. I'll show you in a second how that's done. The stem cells are taken and placed in the freezer. The stem cells are hardy little guys. They're preserved along with some chemicals that allow them to survive the freezing process just fine. We then take the patient, we admit them to their transplant ward, commonly, although there are a few centers in Canada that do this as outpatients, and then we give the patient higher than normal dose chemotherapy. After the chemotherapy is given and cleared by the liver or kidneys, the stem cells are taken out of the freezer. The stem cells, of course, were in the freezer while the chemotherapy was given, so they're undamaged by the toxicity of the therapy. They're thawed, typically just in a hot water bath, and then given back to the patient through an IV line. The stem cells are smart, and they know where to go through complex mechanisms, and they make their way directly to the bone marrow and start recovering counts. It typically takes around 12 to 16 days to recover blood counts following autologous transplant, but the exact timeline varies a lot from patient to patient. This was the original way in which collect stem cells. So patients are taken in the operating room. Typically it's done under general anesthesia, but there is some variation on that. Patients are placed face down on the operating room table. We harvest bone marrow directly from both posterior superior iliac crests. The dose in which we harvest varies based on the recipient weight, but typically ends up being usually between 500 milliliters and a liter of bone marrow. This is then taken to the lab. It's given preliminary checks, and then typically infused in the patient the same day. This was the only way of collecting stem cells until the 80s and 90s, in which they realized you could collect stem cells from the peripheral blood. Peripheral blood stem cell collection is much easier and safer, and it doesn't require hematologists to get dressed up like surgeons and go to the operating room. So it's generally speaking the preferred method in most cases, and is always the preferred method in autologous transplant. There were a couple randomized trials done that established the superiority of peripheral blood stem cell collection for autologous transplant. So patients are given typically a few days in a row of high dose GCSF. This causes stem cells to mobilize from the bone marrow out into the bloodstream, and then they're collected using peripheral blood apheresis. This process is incredibly safe and takes a few hours to do. To do an autotransplant, you have to have a few key conditions met. We have to know that high dose chemotherapy is much more effective than standard dose chemotherapy, and that the toxicity of high dose chemotherapy must be mostly hematopoietic, or at least the initial dose limiting toxicity has to be hematologic. This, practically speaking, means that most transplants are done for patients with hematologic malignancies. There are some exceptions to this. Rarely we'll do transplants in adults for germ cell tumor or testicular cancer. In pediatrics, there are some other non-hematologic indications, some brain tumors, some sarcomas. But mostly speaking, the fact that the side effects are hematologic means that you're dealing with hematologic malignancies that respond to these chemotherapy drugs. Obviously, if the dose limiting toxicity is something other than hematologic, then transplant doesn't make any sense. So if you can't give a dose higher than 20 milligrams of chemotherapy, or you'll end up with unacceptable nephrotoxicity, then transplant's not going to make a difference there. So the dose-limiting toxicity has to be hematologic, and there has to be a big gap between hematologic and non-hematologic dose-limiting toxicities for this all to make sense. Patients have to have suitable organ function to tolerate high-dose chemotherapy. Obviously, they have to have good liver and renal function. And importantly, patients will be neutropenic for sure for at least 5 to 10 days following autologous transplant, and risks of febrile neutropenia are very high, and so they have to be well enough that they can tolerate the inevitable febrile neutropenic episode that happens on day 7 post-transplant. Lastly, for reasons that I won't go into today, transplant really works better as a consolidation of initial treatment. We would never do a transplant as the first line therapy for patients with any type of cancer. It's typically done following several cycles of standard dose chemotherapy in which the patients had a response. So patients typically require at least a partial response or better to initial therapy to qualify for transplant. Allogenic transplant is a completely different story. So allogenic transplant has a very similar process, and you would be forgiven from looking at the first couple comments here that it looks pretty similar. In allogenic transplant, we collect stem cells from a donor. In this specific setting, the donor is anyone other than the patient. Typically, it's either a family member or a volunteer on a donor registry. The patient is given usually high-dose chemotherapy, although sometimes we use lower-dose chemotherapy with allogenic transplant. We then infuse stem cells after the chemo's done. Then we see blood counts recover a few weeks later. The big change, though, that the donor is anyone other than the patient has big implications. And that means that after transplant, the recipient now has a brand new immune and blood-making system. And this has very big benefits, but also has very big consequences and a lot of potential harm. There are a few reasons why you may want to do an allogenic transplant. You may want to deliver higher than normal doses of chemotherapy, just like you would an autologous transplant. However, this was your only reason in which you do a transplant. An allogenic transplant certainly wouldn't be your first choice. Autologous transplant, as I'll show you later, is much safer. And this shared benefit really would, if that's your only goal, you would certainly do an autotransplant first. You get a few important benefits for some patients. So you can fix a broken or dysfunctional blood-making system, hematopoietic system. So patients like that have severe aplastic anemia, or patients that have sickle cell disease or thalassemia. For now, for these diseases, at least as of today, this is the only curative option for these patients, and represents a common indication for transplant in pediatrics. You could do transplant to replace the dysfunctional immune system in patients with congenital immunodeficiency syndromes, and again, this is a common indication for transplant in pediatrics. Reason number 4 is really the driving reason behind allogenic transplant in adults, and that's that it allows for the development of a graft versus tumor effect. And I'll talk about this a little bit later, but this is a process in which the new donor immune system attacks and kills any residual cancer cells that might be left in the body. Obviously, to do a transplant from someone other than yourself, you need a donor. Probably 90 to 95% of patients today will have a viable donor. This was not always the case. 20 or 30 years ago, before unrelated donor transplant became commonly done, only a minority of patients would have a viable donor, and indeed that was a common technique for studies to be done. They'd be randomized based on whether you had available a donor or not. That is largely fallen by the wayside, and as mentioned, we now are able to find a donor for almost every patient. We use HLA typing to determine what options are available. HLA is a set of markers expressed on the surface of many blood cells. They act like a genetic fingerprint that tells the immune system what is friendly and what is foe. There are at least 4 different markers that we look at on the donor and recipient to determine which donors are potentially matched and which ones are not. HLA is on chromosome 6. It's inherited in typical Mendelian fashion. Every center that looks for donors will match for at least A, B, and C in class 1. and DR in class 2. Some centers will also look for DP and DQ matches as well. Everybody has 2 copies of chromosome 6, one they inherited from their mother and one from their father. So centers will at least look for matches out of 8, 1 copy of A, B, and C and DR from each parent. Some centers will, and so that donors are usually talked about in terms of matches out of 8, so like an 8 out of 8 donor or a 7 out of 8 donor. Some centers will talk about 10 out of 10 donors or 12 out of 12 donors, depending on their preferences, and it varies based on where you get your transplant done. We will typically start at the top and make our way down here. We'll start usually with looking for matched sibling donors. Again, it's inherited using classic Mendelian genetics, chromosome 6, so 1 out of every 4 siblings will be a full match for the potential patient. And this is how they did transplant originally. This was the only viable donor option in the 70s and 80s. Matched unrelated donors became popular in the 1990s on the basis of several large retrospective trials done through massive transplant registries that showed that well-matched unrelated donors offer outcomes that were largely comparable to matched sibling donors. And we're to the point now where we have about 15 or 20 million people worldwide have signed up to be volunteer stem cell donors. The odds of you having a match, an 8 out of 8 or a 10 out of 10 match on these registries varies a lot based on your ethnic heritage. People of Caucasian descent have a higher likelihood of having a match than people of other ethnic backgrounds. This is due to a couple reasons. Firstly, the large unrelated donor registries tend to be located in wealthy Western European countries. Establishing donor registries is a lower priority in developing countries, rightfully so. People of Caucasian descent actually have a smaller genetic gene pool. We all descended from a small group of people that moved north from Africa thousands of years ago. Tragically, the group of people that have the lowest likelihood of finding a match are people of African descent. And so it varies, a Caucasian will have an 80% chance of having an unrelated donor match. A person of African descent will be down to sort of 20 or 30%. So that left a huge unmet need, but that unmet need has largely been filled by haploidentical donor transplant. So this was historically not really done because of poor outcomes. A half match, obviously, you would think you would have more complications because it's not as well matched, and this was the case up until some really pivotal studies were done by the group at Johns Hopkins that showed that through the addition of post-transplant cyclophosphamide, you can safely do haploidentical donor transplants with outcomes that are pretty similar to those seen in better matched donors. Lastly, umbilical cord blood is commonly done in children. Umbilical cord blood is typically discarded after childbirth, and it is a very rich source of stem cells, but we dose stem cells in terms of recipient weight, and for adults you need many more stem cells than you do for children, and typically there's not a huge volume of stem cells in the umbilical cord just because the volume of cord is low. So it is an option in children. It is very rarely done in adults these days, especially because haploidentical donor transplant has been proven to be safe, and it is more readily available. As mentioned, we will typically start with matched sibling donors, given that they are readily available and have been the historical standard. As mentioned, there have been multiple large registry studies that show that unrelated donor transplant offer equivalent outcomes. There are a couple of cons to unrelated donors. They do cost quite a bit more. The cost to a center depends a lot based on where the stem cells are coming from. But stem cells, for example, from most European registries will cost in the neighborhood of $10,000 per product procured. And it takes another month or so, at least, to work up a donor in another country. So it adds a bit of delay to the transplant process. Alternative donor transplant, is still fairly new. It really took off in Canada in 2012, 2013, based on, as I mentioned, the phase 2 studies done out of Johns Hopkins. The best data we have now suggests that the outcomes are largely similar to matched siblings and matched unrelated donors. But while the registry studies comparing unrelated donors to matched siblings involved thousands and thousands of patients. The registry studies comparing haploidentical donors to other options typically involve hundreds of patients. And so the confidence in that statement that their outcomes are similar is a fair bit lower. As mentioned, the replacement of the donor immune system has some important consequences. Recipients of allogeneic transplant remain immunocompromised for much longer than autologous transplant recipients, which results in much higher rates of serious infections following transplant. The replacement of the allogeneic transplant immune system with the replacement of the donor immune system with the recipient immune system places the patient at risk of this graft versus host disease phenomenon. So say, for example, I was the donor to one of you that needed a transplant, it would be my white blood cells floating through your veins, finding pathogens to attack. And while hopefully my white blood cells will attack COVID, they can also attack your liver or your skin. And some graft versus host disease, unfortunately, is fairly common. Depends on which study you look at, but between 50 to 80% of patients following transplant will have some graft versus host disease. Graft versus host disease is usually manageable, but we certainly do see patients in clinic that have debilitating long-term consequences from graft versus host disease, can interfere seriously with quality of life and can be life-threatening. That's fortunately not common, but it's certainly something we see on a regular basis. Acute graft versus host disease is fairly straightforward. It is a triad of diarrhea, skin rash, and increased liver enzymes, typically AST and ALT. It occurs within the first 3 months following transplant. Chronic graft versus host disease is very heterogeneous. There are tens of manifestations of it. If there is such a thing as typical graft versus host disease, it resembles scleroderma. So patients will have a thickened, tightened, hidebound skin. They will have oral and ocular sicca symptoms from sclerosis of tear ducts. They will have other organ involvement. If they have liver involvement, it typically is cholestatic enzymopathy as opposed to transaminitis. Chronic graft versus host disease is challenging to treat when it happens. I mentioned, the various ways in which we procure stem cells when I was talking about autologous transplant. Almost all autologous transplants are done using peripheral blood stem cells. There was a couple studies done that showed, a couple randomized trials done that showed superiority of peripheral blood stem cells. There is much more variation in practice in allogeneic transplant. Because you do collect a slightly different product, peripheral blood collections have somewhat higher numbers of stem cells, but also higher levels of committed progenitors. And this results in more rapid engraftment. So that is an advantage to peripheral blood stem cells compared to bone marrow. But you also collect many more donor T and B cells, and this results in higher rates of graft versus host disease. So peripheral blood stem cell collection, we know from randomized trials, is associated with a higher rate of graft versus host disease than bone marrow transplant, than bone marrow as a source of stem cells. So again, peripheral blood stem cells is certainly easier on the donor. It doesn't involve a surgical procedure. We just mobilize stem cells using GCSF. Bone marrow harvest is certainly harder on the donor, but again, it is a very safe procedure. We harvest bone marrow directly from the iliac crest in the operating room. Umbilical cord blood is, I mentioned, no risk to the donor because it takes a product that would otherwise have been discarded. A big advantage with peripheral blood stem cells, as I mentioned, is faster engraftment and also that convenience factor for the donor. The big advantage to bone marrow, as mentioned, is the lower rate of chronic graft versus host disease. Peripheral blood stem cells result in higher rates of graft versus host disease, but they result in faster engraftment compared to bone marrow. Most adult transplants are done with peripheral blood stem cells. Most of our transplants are done for malignant diseases, and so while peripheral blood stem cells result in higher rates of graft versus host disease, that is generally tolerated, knowing that you have faster engraftment and at least theoretically more graft versus malignancy. Again, this is a topic of debate, and there are studies that suggest that we should be doing more bone marrow harvest than we do. Part of that also may be a human factor in that many of us would rather write an order for peripheral blood collection rather than visiting the operating room to do a bone marrow harvest. Again, to sort of summarize, an autotransplant versus allotransplant. Again, autotransplants, patient donates to themselves. Allogenic transplant is really anybody else, typically a family member, sometimes an unrelated donor. Autologous transplant is a safer way to deliver high-dose chemotherapy. An allotransplant, you get that benefit, but you also get a new immune system and a new blood-making system, which has, good things and bad things. It causes graft versus host disease, or results in that potential graft versus malignancy effect, which again is important as to why we do transplants in patients with acute leukemia in particular. The prolonged immunosuppression associated with allogenic transplant results in higher rates of graft versus higher rates of mortality, and that's due to infections as well as graft versus host disease. In general terms, and there are exceptions here, we usually use allogeneic transplant for acute leukemia, both AML and ALL. Acute myeloid leukemia is the most common indication for allogeneic transplant in Canada and indeed worldwide. For patients with myelodysplasia and myeloproliferative diseases, these are stem cell deficits, stem cell defects, and so allogeneic transplant again is the only curative option and the only option that's commonly done. And again, for patients with immunodeficiency or hemoglobinopathies, allogeneic transplant, at least as of today, is the only curative option and the only transplant option, certainly. Autologous transplant is reserved for patients with lymphoma myeloma. The most common indication for transplant in Canada and also worldwide is multiple myeloma. Multiple large randomized trials have shown a benefit to transplant upfront in patients with multiple myeloma. All that kind of makes sense. I mean, the short answer is that each transplant indication is supported by specific data. In some situations, it's randomized trials, for example, myeloma. In some situations, it's registry studies, for example, MDS. It generally does make sense, though. Obviously, in non-malignant diseases, there's no benefit to graft versus host disease, really your goal is to give them a brand new immune system, and so you would choose a allogeneic transplant from bone marrow. In AML, ALL, MDS, and MPN, again, the stem cell is defective, and so we usually will prefer an allogeneic transplant, and we would usually use peripheral blood stem cells. To sort of wrap things up here, allogeneic transplant is done, again, with the only reason to do an autologous transplant is to safely deliver higher than normal dose chemotherapy. Allogeneic transplant, you get that, but you also get a brand new immune system and a brand new blood-making system. And again, the indications for an autotransplant are lymphoma and multiple myeloma, predominantly, with other diseases less commonly done. Allogeneic transplant is done for acute leukemia, MDS, and myeloproliferative diseases. Complications are similar, but of different grades. So both autotransplant and allogeneic transplant are associated with significant rates of infection due to the immunocompromise you get following transplant, much higher in allogeneic transplant than autologous. Both of them are associated with risks of organ failure from the chemotherapy. In allogeneic transplant, you also have a risk of graft versus host disease. In adults, tragically, the risk of death following an allogeneic transplant is in the neighborhood of 20 to 25%, depending on the patient. And autologous transplant, it's more like 1 to 5%. So again, autologous transplant is much safer. I hope this was a nice introduction to transplant. I know you'll be going through a lot of this in much more detail in subsequent talks. And I very much hope this was a useful endeavor for you and a useful introduction to transplant. Thank you.